Ladies and gentlemen, dear friends and colleagues, I'm Dr. Devi Nair, live from St. Bernard's Medical Center in Jonesboro, Arkansas. Welcome to the third day of Rhythm Interventions Online, the exclusively online conference for electrophysiologists. We've had two very exciting Rio days already, the first day focusing on AF ablation, and the second day focusing on complex arrhythmias. We've had more than 5,000 people participating these last 2 days from around the globe and many more following us on demand. Virtual conferences like Rio have played an undeniable role in helping us stay connected through this pandemic and allowing us to move the field forward with continuing collaborations. Sit back and enjoy the experience on this final day focusing on device technologies. With that, let's move on to session 1. Welcome to the first session of Day 3 of Rhythm Interventions Online. We have got some great presenters lined up to kickstart the day. I'm joined by Dr. Vivek Reddy, Director of Cardiac Arrhythmia Services at the Mount Sinai Hospital and the Mount Sinai Health System, and Dr. Gaurav Upadhyay, Associate Professor of Medicine and Director of Heart Station at University of Chicago Medicine. Hello, Vivek, and hello, Gaurav. Thank you for joining us. Dr. Reddy has served as lead investigator on several multinational clinical trials advancing the field of EP and is a true innovator. In 2014, he implanted the world's first miniature leadless pacemaker. I'm now going to hand you over to Vivek, who is going to take us through the role of leadless pacing and what do the trials tell us.
Thanks very much, Devi. So my role is to discuss leadless pacing. What do the trials tell us? And please note that I do have conflicts of interest as noted below. These are manufacturers of leadless pacing devices. So this is the first in human study that we did about 5-6 years ago. This was ourselves as well as Dr. Reinoud Knops and Dr. Johannes Spursel and Dr. Peter Nuzzo and colleagues. And what we showed in this initial 3-center, 33-patient study was that indeed one could perform leadless pacing with this device, which showed good pacing thresholds, R-wave amplitudes out to 1 year. And this was followed by the larger registration trials with two different devices, the nanostim on the left and the micro on the right. And what you see, and here actually the two publications, the devices were different. The nanostim used a helix to affix to the myocardium versus the micro used tines to affix to the myocardium. I should also note that there's a third device that's just starting clinical trials called Empower, which is in some ways a hybrid between these two. It is longer and thinner like the nanostim device compared to micro, but it uses tines for its fixation mechanism. Again, this just shows you how these different devices fixate. So first, let's look at the nanostim device. This is the leadless 2 IDE trial, the registration trial, included about 526 patients. If we just look at the overall event rate in terms of complications, it was 6.5%. Now, what are these complications? Well, pericardial tamponade occurred in 1.5% of the patients, though that requiring intervention was only in 1.2%. Vascular complications certainly occurred, but given that this is a 18 French sheath, it's actually we were actually quite pleased that it only occurred in 1.1% of the patient population. Device dislodgement did occur in 1.1% of the patients, in which the device was then immediately removed. If we also look at the time course of these complications, what we see is that the complications occur up front. Once you get beyond the initial 30, 60-day period, we really didn't see any adverse events from these devices. Now, again, that was followed out to about a half a year. And here we looked at long-term performance in terms of battery voltage, sensing, pacing, impedance, and at least out to about a year and a half, everything looked pretty good. This is just a comparison, a propensity match comparison to traditional transvenous devices. It's showing that the leadless pacemaker performed much better. And again, what you see is the complications occur up front, and then afterwards it's relatively flat, at least out to a year and a half. Versus with the transvenous pacers, you have more events up front and you have continued events over the course of time. And that's going to be a recurrent theme that we'll see over and over again. Let's see here. Okay, and this is just to show you that there was 71% reduction in the number of events. Now, unfortunately, this particular device had an important battery failure. In October 2016, the manufacturer issued a worldwide alert because there was abrupt loss of function and communication with this device. And at that point, there was a battery recall and device recall for that matter. In 2017, we reported the implant time from implant to failure was around 3 years and ranged from 2.3 years to 4 years. And because of this, the device has been redesigned. There's a new device using more standard battery chemistry. This is called the Aviator device, and this FDA trial actually has started with the first cases implanted. So hopefully we'll see this in clinical practice at the end of the year or next year. And I say end of 2021 or 2022, I should say. Now, this is a micro device that I think many of you are familiar with. This device has been FDA approved as well as CE mark. It's a device that's 24 millimeters long. It's delivered through a 20 French femoral sheath. And as we previously said, it's fixated by these 4 barbs. There's a catheter that's used to deploy this device. And this is the data from the registration trial. Again, similar to the nanostim device, we see the complications occur up front, and then the curve goes relatively flat. And now that was the initial trial. If we look at the different types of complications, you see that vascular complications occurred in 0.7%. And if we look at the traumatic cardiac injuries or pericardial effusion, it was in 1.6%. So the total complication rate here was 4%. Now, let's move from, let's skip forward here. Here's a comparison again to a matched historical control of traditional transvenous devices. So the historical control is in black, the leadless pacemaker is in red, and again, what you see is about a 50% decrease in complications with the leadless pacemaker. Again, I should note this is a propensity match analysis, just as the previous one. This is not a direct randomized study, and of course, there's the potential for confounders. Now, after that initial IDE, this is a post-market study that was published, including almost 800 implants by 150 operators at 96 centers in 20 countries. And importantly, there was only 1 pericardial effusion, 1 device dislodgement, and 1 procedure-related death. So it was actually the complication rate decreased significantly. So the total major complication rate, and here you're comparing the post-market study on the left and the IDE on the right, and you see the complication rate about halved. It went from 2.9% to about 1.5. Now, this is not statistically significant, but still, I think it was moving in the right direction. Now, after that initial report, there was another report including more patients included in the post-market study. So let's look at this. So this includes 1,817 patients in the post-market study, compared again to the IDE patients, 726. Now, what you notice here is that compared to the IDE, there were more patients in the post-market study that had a condition that precluded the use of a traditional device, 24%. I'm going to come back to that in a bit. If we look at the pacing indication, the main indication, just as in the IDE, was bradyarrhythmia with atrial fibrillation. And then after that, you have other indications, the sinus node dysfunction, AV block, and in the post-market study, more patients with syncope were receiving the device. What were the outcomes? Well, again, the procedural parameters look good. You see the battery voltage was good. This has not seen any of the battery issues that the nanostem device has seen. There was no change in pacing output as well as in ohms in the impedance. Now, this is the post-approval study. Here you see the complication rates, and we're going to compare the three. So in gray, that's the post-approval study. What you see here in the dark color is the IDE study. Now, that was not statistically significantly different, though the hazard ratio was 0.71. But if you look at a transvenous control, again, propensity matched, what you see is an about 60% decrease in complications. So again, all the propensity matched studies suggest a significant decrease in complications compared to transvenous devices. Again, with the caveat that these are not randomized trials. Now, I told you that about a quarter of the patients were ineligible. So if you separate these patients into three groups, these are the patients, the 546 where transvenous devices were precluded, the 2,000 where it was not precluded, and then 500 patients, traditional transvenous device. What you see here, and the reasons, by the way, for precluding was because of venous access issues most commonly, or a history of infection, and other reasons like cancer or other high-risk complications. Now, if we look at this population, what you see is that these patients that had transvenous devices that were precluded were a little younger and had fewer atrial arrhythmias compared to the other two groups. However, they tended to be a little bit sicker in other ways. You see COPD, diabetes, renal dysfunction, use of dialysis, and prior devices were much more frequent in this population. And so when you actually compare the patients, the leadless patients who transvenous devices were precluded versus those that were not precluded, there was no significant difference in complications. However, when you compare these patients, the precluded patients here in yellow, and you compare to either those that were not precluded in dark black or the transvenous patients in gray, there was a higher mortality. And it seems to be related, again, not to complications related to the procedure, but rather to underlying substrate. Now, more recently, we have the AV device. So based on the accelerometer, the device is able to detect the atrial kick. So you can see here, this is the accelerometer tracing on the bottom. There's A1, which is when the ventricle is contracting, A2, the valve is closing, A3, when passive filling, and A4 is actually the atrial kick. So the device is able to detect this A4, and in the initial evaluation of the MARVEL study, what was seen is AV synchronous pacing went from, haphazard at 40% when programmed VVI to 80%. Now, the algorithm was improved somewhat, and it was reassessed in the MARVEL 2 study, and this is about a 75-patient study. And what you see here is that the rate, again, of AV synchronous pacing went from 26% to a mean of 90% and median of 94%. Also, we see that when you look during a stress test, what you see is that the synchronization drops a little bit when the heart rate increases, but overall stayed 70 to 80 to 90%. Throughout on average. And you also see about a 9% increase in stroke volume when you use this VDD approach. Finally, one thing that we want in our leadless pacemakers is the possibility of retrievability. So I just want to go through very quickly these data. The nanostem device had a element on the back end where you could grab this device, and we showed some preclinical data that this was possible out to 2.5 years. There was an initial clinical experience where we published our experience in about 15 patients. And what you see, This was both acute as well as chronic in 10 of 11 patients. There were no procedure-related adverse events. We were able to remove the device in the majority of the patients, including out to 1,188 days. And you see over here on this, when we removed this, there was some tissue on this one. So you could see that the tissue sheath actually that was forming over this. We actually, because of the recall, we had the opportunity to look at more explantations. And this is a publication looking, and what we saw was 90% success in terms of removal of these. In the failures, it was usually because the docking button was inaccessible because of tissue overgrowth or coverage by the subvalvular apparatus. Though in one case, there was a docking button that was detached. This is another issue that was fixed in the new Aviair device. So overall, though, if we look at whether the duration of implant was 0 to 1 year, 1 to 2 years, or greater than 2 years, again, no statistically significant difference in explantation success. Finally, I just want to talk a little bit about some recent publications that we did. This is a single center experience, and what we saw in 34 patients where the duration from implant to retrieval was mean of 4 years and up to 6.1 years. What we saw, and here's the reason, was mainly because of battery failure, as you see, and the success was 85%. And what it turned out that we actually separated these into two different groups. One group during when we looked at the device on fluoroscopy, there was minimal motion, and one group there was a lot of motion. So there were 25 patients where there was significant swinging just with the heartbeat, and other patients, 9 patients, where there was not significant swinging. What was interesting is when there was significant swinging, our success of explantation was 100%. But when it was not, our success was only about 50%, with a, not surprisingly, increase in fluoro time. So that's one easy way to tell on fluoroscopy what your chance of success. What about the micro device? Certainly there was a publication looking at early retrieval, early being defined as less than or equal to 3 months, so really pretty early, and showing the success was quite high in these 29 patients. What about late? Well, there is one experience. This has been published only in abstract form. We looked at late retrievals in 6 patients with micra, ranging, you can see, from 287 to 1,200 days. And we were successful in 5 of 6 patients. The one we were not successful, there was tissue overgrowth over the device. So let's look at last slide here. Just to conclude, let's see. Yeah, just to conclude. So leadless pacemakers, I think what we've learned is that they're safe to implant. They result in few complications and perhaps fewer than transvenous devices. It is possible to have AV synchrony in the majority of patients. Retrieval is possible with the nanostim device. With the micro device, retrieval has been demonstrated, though the experience is very early. What's the future going to be? Well, I think it's all about communication. Communication with subcutaneous devices to deliver ATP, communication with other such devices such as these CRT devices to deliver complete leadless CRT, as well as the possibility for AV coordination to get DDD activity. Thank you very much.
Thank you, Vivek. You have shown how the technology has been a game changer in how we take care of patients with bradycardia by eliminating the Achilles heel of transvenous pacing, pocket and leads. Due to time constraints, I'd now like to pass over to Gaurav, who has been a leader in physiologic pacing, and he'll be talking about his bundle pacing versus resynchronization. What do the trials tell us?
All right, good morning and good afternoon to all of the attendees for this wonderful virtual meeting. Thank you, Dr. Nair, thank you, Dr. Reddy. It's really a pleasure to be here, and thank you to the organizers. I'm charged with the task of discussing HIS versus biventricular pacing for resynchronization. What do the trials tell us? So let's take a step back here and think about what data supports clinical practice. We're well aware of the pyramid of data that can inform practice, beginning with background expert opinion, individual case reports or case series, cohort studies, and non-randomized studies as well. How does the data for His bundle pacing fit in? Well, there was an explosion really of data not from a traditional source, but rather from Twitter, from informal sources of information. And where would this fit into the pyramid? Well, it would fit in just below individual case reports, since indeed those tweets aren't peer reviewed. Well, why does this matter? Should we even take this into account when considering data? Well, it's no doubt that the data that we receive socially from these informal references are a great way to spread information. One could argue that in terms of scientific discourse, that bite-sized tweets are able to spread significant information and significant impressions, here close to 12 million impressions for tweets having to do with His bundle pacing, and that has translated into significant increase in use. Now, is that the right thing? Should we use that to guide us? And I would certainly say that we should think about this question with respect to His versus biventricular pacing, in particular with respect to randomized controlled trials. Well, why perform randomized controlled trials? And simply put, it's to discern actual treatment effect. So my task here is made more challenging, having to do with the type of data that we're evaluating. So if we take a step backward and ask, what is the evidence base for cardiac resynchronization therapy? It begins really with the case report in 1996, first describing biventricular pacing for dilated cardiomyopathy. And because this was a completely new approach, subsequently, there was really an explosion of trials over the ensuing decades, with multiple randomized controlled trials published in featured journals having to do with the approach of biventricular pacing for the treatment of heart failure. Here are some of those trials over the ensuing years. And importantly, these were not just trials of biventricular pacing versus medical therapy, but also included patients who did not receive medical therapy by itself. All of the trials that you see in blue are actually trials that were greater than 500 patients in size. In yellow here, we see the first case report of His bundle pacing for dilated cardiomyopathy. And indeed, it's now more than 10 years later that the first crossover comparison was reported by Lusgarten in 2015, and only one randomized controlled pilot study was published in 2019. So although there are a spectrum of ECG patterns in heart failure, it is certainly clear that the preponderance of data, of randomized controlled data that's high quality, it favors use of biventricular pacing. If we were to develop a scorecard looking at each of these ECG patterns and ask the question, well, if we look at where the evidence is pointing us, looking at non-randomized prospective data, or where we need more data, we can compare His versus biventricular pacing. So let's begin with the narrow group. Importantly here, both His and biventricular pacing are in the guidelines. There's a two-way indication to consider His bundle pacing or CRT for patients with AV block who are expected to receive a high degree of pacing. And that indication is also present among patients who have expected pacing requirement more than 40% of the time. In the European guidelines, there's a class 1 recommendation to consider His bundle pacing as part of an ablate and pace strategy. Now, where does the data from the guidelines come from in this regard? There was a systematic review of the data of His bundle versus biventricular pacing that was conducted by the American Heart Association and the American College of Cardiology. And essentially the data suggested that His bundle pacing was better than right ventricular pacing and similar to cardiac resynchronization for improvement of ejection fraction after pacing. Why might this be? Well, the justification has to do with using the His-Purkinje system to maintain ventricular activation. In this video here, a patient has undergone AV junctional ablation for atrial fibrillation and is now undergoing His bundle pacing, and there's a virtually identical QRS complex. With respect to biventricular pacing for narrow QRS, there is actually randomized controlled data available, and unfortunately here the signal is towards possible harm. In particular, the ECHO CRT study suggested a trend towards increased incidence of death in patients receiving CRT who had a narrow QRS and heart failure at baseline. Other randomized controlled data are available from BioPace in a very important study of over 1,800 patients who were randomized to receive RV versus biventricular pacing, and indeed was not published, and yet there was no benefit of biventricular pacing versus RV in all comers. So when putting this data together, at least among narrow patients, the prospective data suggests there might be benefit to His, but randomized data suggests that there's potential harm for biventricular pacing in that group. Among left bundle branch block, which is the primary cohort of patients who are receiving biventricular pacing, we do have some data to guide us for His as well. Beyond the improvement in surface QRS, which has been notable, the question has been put forth, what is the mechanism of this kind of improvement? In high density mapping studies that were performed evaluating the mechanism of left bundle branch block, we performed recordings of both the right and the left-sided septum. And this study was to attempt to understand what was the mechanism of improvement with His bundle pacing. What we found was that among patients with intrinsic narrow QRS, that the majority of these patients have intact Purkinje activation, and that ventricular activation follows intact Purkinje activation. Among patients who meet the criteria of IVCD, there are a number who also demonstrate intact Purkinje activation. In marked contrast are patients who have a wide QRS in whom there is complete conduction block. And these patients have block that is high, where an atrial electrogram may still be recorded. Indeed, these patients have disrupted ventricular activation. The block here is a form of left intrahissian block, which can be overcome or circumvented with His bundle pacing. On these tracings here, we show that pacing at the His first can reproduce the left bundle branch block pattern, and Purkinje potentials are delayed after the local ventricular electrogram. And then subsequently, correction occurs with recruitment of those local potentials. So His bundle branch pacing can correct the QRS by recruitment of latent Purkinjes. This was studied in a randomized pilot study of His versus biventricular pacing. The primary outcome that was explored was an echocardiographic improvement, and although both groups improved, there was no significant difference between the groups, and the study was marred by a high degree of crossover. When looking at intention to treat outcomes, there was a greater trend towards improvement with His bundle pacing, but again, this did not meet statistical significance. When evaluating the per protocol analysis here, change in QRS was significantly different. When comparing the degrees of improvement in the HIS-SYNC trial versus historical controls, we find a similar degree of overall echocardiographic improvement. Putting this together, the data would suggest that clearly there's a role for biventricular pacing, but there may also be a role for His bundle pacing for left bundle branch block patients. Certainly as a bailout strategy, the data is highly suggestive. Right bundle branch block patients pose a challenge. There are patients who undergo biventricular pacing with traditional CRT who improve as super responders or as responders. There are those who are non-progressors. And compared to the natural history of heart failure, there are also those who are actually negative responders to the biventricular pacing. Who is composed of this group? Well, it's these patients with non-left bundle branch block pattern. When evaluating His bundle branch pacing for right bundle branch block pattern, we find that there is EF improvement that can be seen in these patients, and importantly, restoration of the ventricular activation pattern, although more data is needed with respect to clinical outcomes. Perhaps a very important group which is not well represented in these studies is intraventricular conduction delay. These patients do not necessarily have conduction block and would not benefit from His bundle pacing. So intact Purkinje activation cannot be corrected with His bundle pacing either on the right or the left side of the septum. These patients are poorly represented in classical trials of cardiac resynchronization therapy. And although some demonstrate left-sided delay, not all comers do so. And those patients may actually benefit from a hybrid strategy. Dr. Vijayaraman has reported on the use of coordinated His bundle pacing as well as left ventricular pacing to produce significant electrical resynchronization, merging both pacing approaches. So IVCD, importantly here, there may be a benefit of biventricular pacing, but certainly there could be a role for hybrid strategies as well. I would be remiss here to say that His bundle pacing is the future for cardiac resynchronization therapy unless we further improve needs, including improve ease of implant, deliver the lead consistently, have a dedicated generator, and improve thresholds. A pivotal RCT would certainly drive the field forward as well. And is the juice worth the squeeze? Newer approaches of conduction system pacing may indeed be another step forward. Left bundle branch area pacing, it has obviated some of the concerns with His bundle pacing with improved thresholds, delivering the lead deeper into the conduction system, deeper into the septum to capture the conduction system, and has been associated with significant QRS narrowing. And the future may be here with respect to conduction system pacing, not simply pacing up the His, but further down in the His-Purkinje system. Taken together, His bundle pacing is guideline indicated for patients receiving greater than 40% pacing. His bundle pacing is associated with reduced risk of heart failure hospitalization. There's active innovation on delivery tools and sheaths, and mechanistic research is underway with regards to understanding this and other regions for conduction system pacing and tailoring the strategy for individual patients to achieve resynchronization. Thank you again for the opportunity to contribute to our session today.
Thank you, Gaurav, for that great overview on physiologic pacing in cardiac resynchronization. So, Gaurav, what do you think have been the challenges for physicians in adopting this technology for our heart failure patients?
Thank you, Devi. That's a terrific question. I think that critically here, we need to establish an evidence-based, which is high quality. And we have a number of prospective cohort studies which have been already published with respect to His bundle pacing and now emerging data for left bundle branch area pacing. But what we really need is a pivotal randomized control trial in order to transform patient selection. And importantly, we need more longer-term follow-up data which we could collect in a randomized study. So I think that will really move the dial the most. There is certainly very reasonable and promising data to consider this approach as a bailout for patients who are not traditional biventricular pacing candidates. And in selected patients, particularly narrow or non-left bundle with the right bundle branch block pattern, perhaps considering it up front, but certainly more data could drive that needle.
Vivek, any pointers from you?
With regards to Purkinje pacing? I mean, I
Physiologic
guess...
pacing, yeah.
Yeah, a couple of thoughts. Well, let me just tie it back to my talk. I mean, I think that, the biggest downside of leadless pacing right now is the inability to do Purkinje pacing, whether it's His or left bundle or whatever. We have tried to do a few things on the left side, but it's just not practical with current technology. Now, having said that, when we look back over our data in patients who receive leadless pacemakers, the number of patients that actually require an upgrade to CRT is actually quite small. It's only about 5 or 6%. So while it's a limitation, it's not clear to me that it should prevent one from offering a leadless device to an otherwise appropriate patient. And then just with regards to physiologic pacing, I've been following this very closely, and at our center we're certainly doing more and more of it. But it is an issue that we don't have randomized data looking at its utility in CRT patients. I mean, certainly it makes a lot of sense to consider this in patients who fail CS pacing, but I think the lack of randomized data is really a problem, and really one has to think about whether or not it makes sense to offer that as first-line therapy to their patients.
Great points. Thank you again. Thank you again to Vivek and Gaurav for giving such comprehensive presentations. We have an exciting day ahead of us demonstrating some of these great technologies. So without further ado, let's move into session 2, a live case from Professor Richard Schilling at Barts in London.